You're going. Cool. All right. So, what are we going to be talking about this evening here? We're going to be looking at, we're going to be talking about garbage and gold, thinking from inside out. It is a conversation on the difference between chiropractic diagnosis and analysis. So, especially for our young chiropractors in the group, for our chiropractic students. You go to chiropractic school, you learn how to do all kinds of pathology, differential diagnosis, and you're also doing adjusting skills. And there's oftentimes this massive disconnect between the two to such a degree you're wondering, how do these things actually come together? Because they seem so disparate. That's what we're going to be spending this little lecture here, not giving you all the answers, but showing you how these things actually go together. Per the usual, if you guys have any questions, please do put them in the chat box. If you do not want to be formally identified as the person, you can just send it to me as a private message and I will answer it, but then I won't identify who it was, so nobody has to feel worried about asking silly questions or anything like that. So building up from what we were talking about last month, we were talking about a condition known as confusion as we were discussing the idea of the vertebral subluxation complex. When as chiropractors, we are having that taking away from us, even on the inside, it's no wonder we're not sure what to do. Because if one wished to kill a profession to remove its cohesion and its strength, the most effective way would be to forbid the use of its characteristic language. So when we try to remove this concept that we talked about last month of subluxation, then we are stuck playing a different game. We're stuck playing a medical game. We are stuck playing an allopathic game. And the nature of the allopathic game, as we will talk about this afternoon, this evening, is a game of effects. It is a game of naming effects, but not necessarily getting to underlying cause. And we'll show you basically what that looks like. You see, when you go to chiropractic school, one of the things that you will learn how to do is you're going to learn how to elicit a patient history. And so what you need to do is you're going to ask about the present history. You're going to ask them, okay, tell me what is going on. What's its location? What's its mechanism of injury? Is it new? Is it old? What was it onset? What makes it better? What makes it worse? Does it radiate anywhere? What is the quality or the flavor of it feel like? How severe is it on a scale of 1 to 10? What time of the day is it there? Is it there after these activities, that activities, or any other weird things that you've noticed? So then what you're also going to do then is you're going to ask and do a little bit of a systems overview. You're going to say, okay, do you experience any other abnormal symptoms with your eyes, ears, nose, or throat? Do you experience any issues with your heart, lungs, or blood pressure? Do you have any issues with your digestion, your abdominal stuff, your reproductive stuff? Do you have any issues with your skin, neurological issues, and or any other weird things like that? Then what you're taught to do is then you're going to be asking, okay, well, what are some of your medical histories? Do you have any specific diagnoses, that is heart disease, cancer, or diabetes? Do you have any allergies? Do you take any medications? Do you have any past traumas? Have you ever had any hospitalizations, significant illnesses, and or surgeries? Then you're supposed to ask, what do you do in terms of your working day, that is from 9 to 5? What are your daily activities? What are the repetitive stress strain activities? Do you like your job? Is it stressful? Does it involve sitting, standing, bending, twisting, all of that sort of stuff? Then you're supposed to ask, what are you supposed to do from 5 to 9? That is your social life. So we're referring to, what do you do recreationally in terms of sports? Do you smoke? How much stress do you have? Are you sexually active? How well do you sleep? How good is your diet? Do you drink too much? Do you then do any other thing that could be contributing to overall lifestyle, good or negative? So you're taking all of the history, and then what you're told to do is with that, you're then going to go through a concentrated assessment, and you're going to start measuring a few things. You're going to start with their vitals. You're going to start with blood pressure. You're going to start with heart rate. You're going to start with respiratory rate, and you're going to start with temperature. Good on you. You're going to have a look at a few things in terms of their skin, their overall tone, maybe their posture. You're maybe going to push and tap in a few little spots to see if there's anything that is not where it's supposed to be, maybe sticking out. Then what you're supposed to do is you're supposed to look into their eyes, look into their ears, look into their nose, look into their throat, look into any other orifice that you can think of, but probably don't want to. You may want to be listening to their lungs. You may want to be tapping on the back of their chest. You want to really listen to their heart. Then what you're going to do is you're going to start palpating at the certain spot along the spine, but maybe in other areas of the body, seeing if there's anything that's just jumping out at you between your fingers. Then what you're going to do is you're going to go through a series of range of motion tests. You're going to see if the neck's moving right. You're going to see if the shoulders are moving right. You're going to see if the thoracics are moving right. See if the lumbars are moving right. Then what you're going to do is you're going to do a series of orthopedic tests, provocative tests to see if you can elicit a positive response, that is elicit the tissue nature change of injury. You'll do a series of tests there so you can find that out, and also do a series of neurological tests. Usually not a bad idea if you're going to be doing a series of dermatomes, myotomes, deep tendon reflexes, not a bad idea as far as doing pathological reflexes. Then if you're still not sure, and it's a good idea to do this anyway, is if you need to see what's going on the inside, you may refer them for some special studies, something along the lines of X-ray, CT, MRI, if you believe that that's appropriate. If you think that there's a physiological issue, you may be interested in actually ordering some blood tests. So you're going to be looking at doing a full panel, including a red blood cell count, white blood cell count. Then if you're still not sure, then you might need to refer to review advanced images, whether it's going to be an ultrasound, whether it's going to be a PET scan, whether it is going to be some other advanced diagnostics test, so that you supposedly know what is actually going on. That is the game of medical diagnosis. Where in any of that do you find out what you're supposed to adjust? We've identified all of these factors, and they're good, they're important in terms of a patient's health history. And you've gone through a screening. You're looking to find out, is there anything dangerous, insidious, scary going on here? But where in that, when we go to school, do we learn to actually look for what to adjust? And what does having to adjust have to do with any of that? We had a little question through there. So if you've still got that question, just unmute, go forward. You can type it in, I'll keep going. So my point is that, you know, we can all play the diagnosis game, but there's more to it than that. So we need to show how to bridge this kind of gap and this kind of analysis, or these two worlds here. So firstly, what do we mean in terms of the difference between diagnosis and analysis? Well, let's look at the word diagnosis first. Di, prefix, it refers to two. Agnosis, it's a suffix, it's referring to agnostic, that is not knowing. So diagnosis, if you actually break it down into its root origins, it means two don't know. In other words, both the doctor and the patient, and they don't know. So typically what happens is when you would go to a standard GP, medical training, what do they tell you to do? They tell you to elicit a history. They tell you to do the standard, you know, medical assessments and blood tests, things like that, so that you can come up with the NAMED of a certain disease, the NAMED of a certain condition, the NAMED of a certain whatever. And they're trying to stick a label on it. That is what the game of diagnosis is. And in that model, what it says is, it says that if you're going to do a certain treatment, whatever that treatment is, the treatment needs to match what the diagnosis is. Because if you don't know what the diagnosis is, you can't actually prescribe the appropriate treatment. But the thing of the diagnosis is, you to a certain degree are having to put this information together so that you can stick the label on it. But is it possible that you could have different diagnoses, but as a result, you actually, how you get there is two very, very different ways. So this is, we'll show you a little bit on, leads to a bit of a problem, but this is the nature of diagnosis, trying to put a label on something. And that's the way that GPs do it. Specialists, you'll note, they don't really care about your history. In fact, you know, they probably don't like talking to anybody. They have no personality. Some lovely people, but you know what I'm referring to. They are all about what are the facts. They want to jump straight to the special tests. They want to go cut right to, nuts to all the red herrings that could be in a person's history. They want to know, what do the facts show is or isn't going on, so that they know what the appropriate course of care needs to be. Physiotherapist, different, because again, they're putting a lot of weight in terms of history. And then they're going to be doing a whole bunch of tests in the orthopedic realm, in the palpatory realm, focusing on muscles and muscle imbalances, physical medicine, all of this good and important stuff. But you can see that again here, we're putting a huge amount of weight on the history. The patient is telling the physician, This is what I feel, so I need you to work here. Doc, I hurt in my head, so I need you to focus on my head. I hurt in my back, we need you to focus on my back. So we become very narrow in our focus and not necessarily see what's going on. Now, how is it that we as chiropractors really should be going about with these kinds of things? Well, there is a place for understanding history, but you'll note on this little chart that we show you right here, that as chiropractors, we're looking to strike the right balance. History matters, but what we are most interested in is we are also interested in showing what the tests are indicating, but not just putting all of our faith and all of our weight in just one test to the exclusion of all the others, because that would cause us oftentimes to err and miss things if we're looking at things through a very narrow pathological perspective. No, we're going to be doing physical tests, neurological tests, and diagnostic tests, and taking multiple sources of information so that we can figure out what is going on. And this is we're going to show you is going to be the important thing. We are not interested in effects. Let me say that again. Chiropractic is not interested in effects. That is the game of diagnosis. You can put the label on it. So what? What caused it? So, okay, you have sciatica. Well, gee, how did you know that? Oh, doc, it hurts right here. Well, guess what? They basically told you they have sciatica. And if you look at a lot of diagnoses, you see what they are, is it's nothing more than the patient's symptomatology, except in either Greek or Latin, oftentimes with little bits of English. Question is, what's caused it? What causes sciatica? What caused the lumbago? What caused the cephalgia? That's a very different question. And it's recognizing that the diagnosis, the label, was not the original cause of the situation. And unfortunately, the way that so much of the medical system is developed is to identify and treat effects. Chiropractic, we are interested in understanding cause. So whether you would choose to call it a migraine, a classical migraine, a non-classical migraine, a typical migraine, an atypical migraine, an ocular migraine, a vestibular migraine, an abdominal migraine, you get the idea. You can have any number of different diagnoses, different labels to a certain degree. I don't care what the name is. Yeah, I can play the game, but I'm far more interested in terms of what is causing it. That is what we mean when we're referring to chiropractic analysis. It is looking at, from our lens, looking at the spine, and based on what we understand about the mechanics and the neurology, is it possible, if not plausible, that that neuromechanical entity of the spine can be responsible for what is producing a myriad of potential effects? That's how we are marrying these two concepts. In school, we learn diagnosis. We also learn analysis, but we don't know how to put them together. It's the difference between cause and effect. Full stop. Now, what we're going to do then here is we're going to play a little bit of a game here for you. It's called a game of garbage and gold. What's important here is that you understand the difference between the two. To your viewing left, you have garbage. To your viewing right, you have gold. Yay. So let's consider causes and effects. And we're going to think of this now in terms of input and output. So firstly, what are we talking about if we are talking about a phenomenon that we like to call health or coordination? Okay, what is health? Health is the byproduct of eustress, healthy stress, within, from outside, inside of the human body, within its adaptability to, its adaptive capabilities, and it manifests as being well. In other words, gold in, gold out. You put good stuff into the system, and guess what? The system will respond favorably in turn. If you are doing the right kind of physical exercise, you expect to be fit. If you take good care of your diet, you expect to be physiologically well. If you take good care of your spine, you expect for your system, your coordination, your electrics, and your mechanics to be working the way that they are supposed to. Gold in, gold out. Now, the flip of that, disease. It's the end result of pathological stress on the body that the body is actually able to adapt to. So what are we saying here? Garbage in, garbage out. So you don't exercise and you wonder why you have no muscle tone. You eat garbage all day and you wonder why you're obese, and you take no good care of your physical frame whatsoever, and you wonder why things are starting to break down over a period of time. So what we are saying, the way that we are defining disease here, is we're saying that it's the end result of pathological stress. Now, let me ask a question here, and I do and would appreciate some participation here in the chat box. Which of these is a normal process? Simple question. Which of these, as we've just illustrated for you, is a normal process in the human body? I'll give you a minute. Any takers? For any of you who have been on these chats with me before, you know it's like, ooh, he likes to ask trick questions. This must be a trap. It kind of is, but kind of isn't. Which of these is a normal process? Both of them, exactly. Gold in, gold out. That's what you should get. Garbage in, garbage out. That is what you should get. So this is a very controversial, topic, and not a lot of people like this, but do think about it in terms of the supposed lifestyle diseases: cancer, diabetes, cardiac disease, pulmonary disease, all of these different things here. Genetics, yeah, it does play a part, but a relatively small part. The bulk of the factor for all of them is that they are the end result of pathological stress. They're the consequence of lifestyle. And so what do you need in terms of a solution? It means that if the problem is your diet, you need to fix your diet, because the crappy diet is what caused your body to adapt the way that it was supposed to. And as a consequence of that, it manifests into the diseased state, whatever that would happen to be. And so if you change the input, you change the output. Make sense? Hope so. Now, what happens then if a person is doing all of the right stuff, but they're not getting the desired outcome? Doc, I sleep really well. I meditate. I go to church. I exercise. My nutrition is good. I have wonderful relationships with all of my family and friends, but I'm still unwell. Gold in, but garbage out. What this is suggesting here is a different process. And this is a process that is known as incoordination, or is otherwise known in chiropractic as dis-ease, contrast to the disease process. Disease, we said, is a normal adaptive response to pathological stress, garbage in, garbage out. Incoordination, or dis-ease, on the other hand, is saying that everything should be going wonderful, but for some reason, you're getting a poor outcome. Now, what this suggests here is this suggests that the input is not actually the problem, but something is interfering with the innate intelligence of your body's ability to express that health, to function, to work the way that it is supposed to. And the consequence of that is that you get this kind of condition, this syndrome, this dis-ease, this whatever, again, you would choose to cause it. Now, what I would like to point out here, and this is super important in terms of understanding the diagnosis versus the analysis game, and it's this: you will see that in both of these cases, the end product looks the same, garbage. But how you got there is a completely different process, a completely different route. One of them, the person may need to clean up their lifestyle. The other one, they don't need to fix their lifestyle. Their lifestyle is great, but something is interfering with that ability to actually work and function the way that it is supposed to. So if you are trying to focus on the disease only without the understanding of the pathophysiology, that is, how did you get there, You could be treating the effects, but guess what? You may never change the situation one iota. And same thing, if you make the presumption that, if we're dealing with the effect, this must always be the underlying cause. I'm going to say pause a minute there, because that may not be necessarily the case. Let me take even in the very mechanical realm of chiropractic and mechanical, uncomplicated low back pain. Does chiropractic fix low back pain? The answer is no, because in the question itself, it is implicit that low back pain is always a consequence of a person needing to see a chiropractor. What if a person has low back pain because they have a fracture? It's not chiropractic. What if they have low back pain because they have viscerosomatic referral? They've got, let's say, a prostate tumor, something like that. That's not going to be chiropractic. What if the person is morbidly obese and it's putting abnormal stress and strain? And let's also presume they're not subluxated. Is the low back pain because they need a chiropractor? No, in this case. The low back pain is the effect. What was the cause? Well, we have to look and consider the lifestyle factors. And then, as chiropractors, we're going to check to see if the spine is working and functioning the way that it's supposed to see if that at least may be a contributing factor. So what this opens us up to, this understanding that you can have the same apparent end effect, but how you got there was so different, it opens the possibility up so that we understand as chiropractors, this is what our role is, both as a chiropractor and also as the doctor. The chiropractor to identify if and when a person needs an adjustment that may be manifesting in terms of incoordination in their body, or if you need to make an appropriate referral to a different healthcare provider, because guess what? That may be the thing that's actually producing that particular issue. Or maybe it's something you need to advise on, whether it be exercise, sleep, diet, stress, the like, different things like that. So, difference between cause and effect and how you got there. Now, this one really drives the scientists nuts, and they don't want to admit that this is true, but the reality is it is. And it's the limits of empiricism. So the scientific method, A causes B, linear and singular connections. A causes B, and B is only caused by A. Nonlinear systems, what this means is it means that A can cause and have multiple different effects, B, M, or Y. Or you can have what are called multifactorial. And multifactorial means that you can have the same end product, but again, how you got there is completely different. So when people are saying there's no credible scientific evidence that shows fill in the blank, what they're saying is they're saying that there is no straight linear connection between A and between B. And typically we don't believe that that exists. And they're trying to tell you what that's the case. Now, that might be fine in physics, but when we are dealing with biology, specifically living biology, although it's a little bit of a redundancy, we need to appreciate and understand that those rules don't work. The central nervous system of the human body is not a linear mechanism. It's a quantum mechanism. It's nonlinear. It's multifactorial. You can have any one thing in the body produce multiple different effects. You can have any effect caused by multiple different potential things. And you can have combinations of things that combine in different ways that end and manifest in the same apparent physiology, pathophysiology, but how you got there again was completely different. Thus, for you to draw a conclusion without considering the factors of the person in front of you, that population of one, very likely that you are going to be making an error. So we need to have an understanding, a difference between four important words: plausible, possible, probable, and proven. Plausible. Plausible means that we have no evidence whatsoever, but we do understand things about mechanics and neurology. It's like, okay, this is, it makes sense. This is biologically plausible. Possible means that you have even one anecdote where something caused something else to occur. Plausible, excuse me, probable. Probable is how likely is that? And this is actually the great breakdown between what, again, so many people in the ivory tower tell us we should be saying there's no credible scientific evidence. No, what they're doing is they are dismissing all of the anecdotes and they're saying, no, okay, there's no evidence. The evidence we don't have the probability evidence, but there is nevertheless, even if it is considered low value, you know, how much low value do you have to ask or wonder? It's like, okay, something is going on here. You know, we should probably explore this to see how do we actually increase the probability of success. So that disconnect, proven means that there's that direct linear relationship. Doesn't exist in the human body. So what we need to stop doing in chiropractic is be thinking in terms of absolutes. Because as valuable as the scientific method is, the scientific method refers to a verb. It is an action. It is a process of discovery. It is not a place that you arrive at and that tells you what to do. So if we start thinking in terms of plausibilities, possibilities, and probabilities, it will ultimately lead to a lot greater clarity in terms of understanding, okay, when we are looking at, again, a neuromechanical condition of the spine, such as a subluxation, we are not saying that this causes this. What we are saying that it is plausible, that it is possible, but we don't know what the necessary probability is. Now, some cases, some symptoms people experience, yeah, if everything is lining up and saying, yeah, there's something wrong here, and all the arrows are pointing in that same direction, you can say, okay, this is clinically probable. Even if you can't give an exact number, once you've started doing some work, you know, you'd be able to make comments or make observations. For example, you know, 80% of the cases that we see who experience vertigo, they get an improvement when we adjust their neck. Or 70% of the cases where they have chronic low back pain and sacroiliac issues, when we adjust their C2, they start to stabilize to the back. Or if they experience chronic fatigue, that, you know, 50% of people say that they don't just have a little bit, but they actually have a significant improvement in their overall quality of living. You're not making unsubstantiated claims or leaps of logic in that point. You're breaking it down again in terms of plausibility, possibility, and probabilities, not going so far as to say proven. Chiropractic is the cure of fill in the blank. No, doesn't exist. I know that that's what they said 100 some odd years ago, but our understanding has evolved a little bit farther than that. I will say that. So a few examples just to illustrate for you common beliefs that exist in modern society and in medicine, but showing you just how, you know, untrue they actually are. Cigarettes cause cancer. So this is a saying that there's a proven relationship. No, because if this was true, every person who ever smoked a cigarette would have cancer. It's not a true statement. So cigarettes are a risk factor for cancer. That is true. So now we're talking about probabilities. Mercury causes autism. Same thing. There's a lot of people who have been exposed to mercury. They don't have autism. Could it be a risk factor? Now we're at the interface between possible and probable. But what we don't know is we don't necessarily know that gap. And you've got one side who says always and the other side that says always never. No wonder that the twain don't meet, because they're not thinking of it in terms of risk factors. Arthritis causes low back pain. Not a true statement. A lot of people, oh yeah, I'm a little stiff in the morning, and they're just riddled with arthritis. Other people, they've got a sliver of arthritis, and yet they're in absolute agony all of the time. Non-linear relationships. Low back pain is caused by subluxation. Well, if a person's morbidly obese but unsubluxated, guess what? They're probably going to have low back pain, opening the mind up to other possibilities. Same thing goes with a headache. Headaches are caused by subluxation in the neck. Well, what if you have a hangover because you drank way too much last night and your metabolism what's causing it? So again, not the direct one-to-one relationship, or for that matter, the cause of all disease is subluxation. Again, I get where those guys were coming from historically, and they came up with some really amazing ideas. I still espouse to a great many of those ideas, but with the critical mind, we've also got to look and say, Doc, I got to disagree with you on this one, and this is the reason why. Part of the reason is the simple recognition that chiropractic does not make a person healthy. Wait, what? I thought that the purpose of chiropractic was to make a person healthy. No, purpose of chiropractic is to correct a subluxation. Why would you do that? Okay, because the subluxation interferes with the neuromechanics and can lead to, as we said, interference in the normal body function. But let's say a person's unsubluxated, but they don't sleep, they smoke too much, their diet's lousy, they don't exercise, all kinds of stress. Would you call that healthy? They're not subluxated, but I wouldn't call them healthy by any stretch of the imagination. So health is a mosaic of multiple contributing elements. Chiropractic is simply one of those elements. So when we understand what chiropractic's role is, that chiropractic is one piece into what goes to allow a person to be healthy, then we have the appreciation for where our role is in the broader healthcare arena. And it also helps us so that we don't continuously make stupid comments, not understanding the difference between cause and effect. Now, we've gone through all of that. Let me see where we are time-wise as well. Doing good, halfway. What is this one called, if you would? Because I'll tell you, this is the one that everybody wants. They want to keep doing all the dumb, bad stuff. Why? Because sin is so delicious. They want the beer and the donuts, and they don't like exercising, and they like to sleep in. And they like to chain smoke, and they like to be in front of Facebook and TikTok 13 hours a day and playing video games and all this sort of stuff for years and decades on end. But they want to be healthy. Their actions are simply incongruent for that. So they want to put garbage into the system, but they want gold on the other side. What is this called? A fairy tale, insanity. And yet, this is what people come to expect because it's what they're told. You've got this problem here, take this wonder drug. It will help you with this. Yeah, it'll help with the effect. Won't get to cause. And even then, there's going to be knock-on effects as a consequence of that. The consequence of trying to mask unhealthy living so that you can, quote, feel good again, I would argue is one of the biggest lies that is told to culture, all Western cultures in the modern era, that we don't have to do anything, that we are not responsible, that somebody else will come to save us. Now, if there's interference in our body, yeah, we're probably going to need some help. But we're talking at the moment about the lifestyle kinds of things. That is up to you. Now, you might need the emotional support, the mental support, somebody to show you the right kind of way to do it. And how do you know if you're going in the right direction? It's all about the outcome, is the short of it. No, the ends don't justify the means, but it means nothing to be continuously spinning the wheel, going absolutely nowhere. I'm doing all of the right things, but I'm not actually becoming any healthier. I'm sticking with the diet and doing the exercise and all that sort of stuff. Again, if you're doing all the right stuff, but you're not getting the outcome, it means one of two possibilities most likely. Number one, you could be doing the right thing, but in the wrong order. So like solving a combination lock, you can have all three digits, but if they're in the wrong sequence, it's not going to work. And in addition to that, it's also a possibility that they are doing all the right things, but then what we're talking about is that coordination or that incoordination issue. In brief, where the body is not able to express health the way that it should and need to be. And this is then where that chiropractic message often is able to help so many of these different people. So we come back around to this again, the difference between diagnosis and analysis. Diagnosis is the effect. Analysis is the cause. So when you play the medical game, you say you have to have the medical name of this thing before you can do a treatment. Treatment for what? Of the effects. But there's almost no question again gone to what is the underlying cause. That requires analysis. That requires that you use your noggin. that requires that you be doing additional tests or the same tests, but you're looking at them through a different lens so that you can make better sense of them, so that you will not just be treating the effects, you're going to be asking the question out of the infinite possibilities that could possibly be leading to that effect, what is the most probable cause? And I'll give you a hint. Most people, when they come in to see a chiropractor, when you're looking at their background history, their systemic review, all of that, they usually have more than one symptom, one diagnosis going on. And the thing about it is that it doesn't usually make sense. They have 12 different things going on in their body. What's far more likely is that they've got one, maybe two, that is simply manifesting in a different variety of ways. So if you understand your pathology, if you understand your neurology, if you understand your physiology, you can recognize this is what the common denominator is. There are these 10 conditions, and guess what? They all have this one factor in common. Occam's razor, the simplest explanation, is usually the correct one. And in the medical world, so much attention is paid to either severe conditions, fracture, dislocation, the obvious stuff, or it's to pathology, but it's not looking at how this condition called a subluxation can be causing all of those same kinds of things. And guess what, chiropractors? We're the only ones who are actively looking at it. So yes, people could say, there's no such thing as a subluxation. No, you guys are looking at it wrong. Consider the possibilities. You see, if medicine was right about everything, simple. All they have to do is get 100% of cases well, and chiropractic will cease to exist. Simple solution. Not easy though. Why? Because it doesn't exist. Same thing. All that chiropractic would have to do to completely invalidate all of Western medicine is get 100% of people well. That also doesn't happen. Nobody has the monopoly on all things medical and healthcare. Why is that? Because, as we said again, health is a mosaic of multiple different contributing factors. And there are different tiers of abnormal function, abnormal health: physical, chemical, mental, emotional, and even potentially others that go beyond that. So point being is that all of these combine. Your job, again, no matter what your degree is, as far as I'm concerned, you are a doctor of chiropractic. That has two parts to it: chiropractor and doctor. Chiropractor in terms of your analysis of the spine, making adjustments to clear the subluxation to restore normal function. Doctor in the sense of you being teacher. And that is looking at all of the things lifestyle and or appropriate referral when it is necessary, because that is actually the thing that is getting in the way of a person's ability to be well. Again, you need to know the difference between cause and effect, and you also need to know, how did you get there? Is it garbage or is it gold? So, where in particular does this, the stuff that we learn in chiropractic school, where does that actually play into the analysis? Well, let me show you right here. Now, I know that there are going to be some chiropractors out there who say symptoms don't matter in chiropractic. I completely disagree with that. Symptoms do matter, but they require context. And the context needs to come after the physical evidence. You do the tests first, then they ask the patient what's what. It's especially useful on a given day where a person comes into the office for a routine checkup. So perhaps you've done an adjustment and they say, oh, okay, yep, they say, oh, I'm feeling a little bit of this, I'm feeling a little bit of that. Well, ask them a few questions about what's going on in their life and their lifestyle, because it's possible that if they have stress, if they've just come from the gym, if they haven't been, eating well, that they will experience different symptoms that can be attributed to any number of different things. Just because a person may have XYZ symptom does not necessarily mean that they require an adjustment or not. Symptoms require context, and context means that you ask them a few questions about what are you doing for the other 23 and a half hours where they're not in the office every day? What are all of the other factors that could be attributing to what this person is experiencing? So ask some of those questions. You'll get some useful information. As a consequence of that, you're going to be able to get better context and make better clinical decisions with the information you have. Now, what's the information that you have? And this is commonly used in the chiropractic arena. I'm not here to tell you always do this test or this test is necessarily better than this test. What I'm simply going to say is that this here in the prone part of our exam is where we're going to see the most common tests that are used in chiropractic. These are just some of the examples. Number one, well, we can use our palpation, whether that would be static, motion, muscle, scanning, all kinds of different, palpatory things. Our fingertips are capable of detecting subtleties as small as 0.4 millimeters. And in terms of nerve pressures, nerve irritations, guess what? That's about right in terms of what can actually cause an issue. As a simple illustration, if you've ever gotten a strand of hair in your eye, it's like scratching you to death. How thick is a piece of hair? It's 0.15 millimeters. So with fingertips, we're talking about something that is capable of detecting something essentially 3 times smaller. So even the very tiny can cause very profound things. Very useful tool that we have in our hands. Range of motion. This is referring to both global and segmental, and they don't always match. It's possible that you can improve global range of motion, but no change whatsoever to a segmental range of motion. And that, of course, is going to be very important to see and to know, is the system working the way that it is supposed to? Orthopedic tests, super useful. Not because they tell you what to adjust, per se. Orthopedic tests are outcome measures. So, for example, you have a positive straight leg razor, and you decide, for whatever reason, to adjust C2, and straight leg razor improves. Guess what? You did a good thing, and you have an outcome measure that you can demonstrate it. Now, the question is, well, how did you know to go to C2? Why not L5? Why not ilium? Why not sacrum? Why not their metatarsals? That's where you're doing all of your other tests, because if you're checking the low back, even if a person's got a positive straight leg razor, but they've got normal mobility, and even though they may have pain there, that doesn't necessarily mean that is where it was coming from. Again, sciatica, lumbago, even disc damage, okay? Disc is ligamentous tissue. What caused that tissue to injure? Oh, they were bending down to pick up a pencil. A disc is stronger than that. A disc should not rupture from just leaning down. So if it did, why? That would seem to suggest it was preloaded to the point of breaking. Okay, so if it was pre-stressed, where is the original source of that pre-stress? One possibility is it was at the site of injury. But other possibilities that area was the area that was simply bearing the brunt from an issue that was going on somewhere else. Just because where the problem is does not mean that's always where the problem is. And we thus need to go through a series of additional tests to know what does what. Other ones commonly used in chiropractic, leg length inequality, whether that is done in a supine, a prone position, or checking a person's posture in an upright position. You can use these as biometrics to see how do things change and improve pre and post adjustment towards normalcy. That's how you can identify, okay, where are the spots in the spine that things are not quite working right? Yep, something's not going on right there. And again, we're making a little bit of a logical leap, but it's like, okay, we can definitely see how these things are connected. So we're going to work on this. And then what? Give the body the opportunity to do the healing, because you, doctor, you're not the one who does that. If the person has that condition known as incoordination, interference with that normal function, it means that you need to get rid of that cause of interference and then just let those innate mechanisms do what they are supposed to do. Neurological tests. You can check thermography. You can do heart rate variability, pulse oximetry, blood pressure, pupillary right reflexes. You can do functional neurology, stress testing, kinesiology. any number of things that are assessments of a person's neurology. You can then challenge and combine that with some of your physical movements to see, okay, if I challenge a segment this way, does the arm go weak? If I challenge it the other way, does it stay strong? And then I challenge it the other way, oh, it goes weak again. So what it's doing again is it's suggesting, irrespective of the symptomatology, something's not working right. But when I do this, it fortifies, it strengthens, and we do better. So this is how we're, again, if we're doing multiple different tests, and there is no one single chiropractic test that is the best, but I want you to imagine in your clinical practice that when you're about to work with a patient, you do 4 functional tests, okay? And let's say that 3 of those all say you need to make a certain adjustment, 1 of them doesn't. The weight of the evidence, what's that called? Oh, evidence-based practice, following the evidence. 75% of all the evidence says this is what's going on, so I made a decision to do that. Versus let's say that, okay, 1 test said it was this, and then 3 said that it was something else. Well, guess what? Math isn't on your side here. So that's where you're going against what the evidence shows. If it's a 50-50, first doctor, do no harm. So rather than putting all of our faith in just the 1 test, very important, chiropractors, when you're analyzing for cause, you're looking for multiple pieces of information that are all indicating the same thing. You get to decide what weight you put on individual tests to determine, is this one useful, or do I prefer to do something a slightly different way if it gets you to the right kinds of results and outcomes. Now, the last component, imaging, you don't do this on a routine daily basis. That is, you don't re-X-ray somebody every single time they come into the office. That's silly. But when we're looking to understand the mechanical elements of vertebral subluxation, that is the articular misalignment component, it's super useful to see and to know exactly what you are working with. You can take a huge amount of the guesswork out of the equation by simply looking and knowing what it is that you're dealing with, so that you've got the additional information of the structural married with the neurological. That there is how we can make the best possible clinical decision in the chiropractic context to, in principle, elevate the probability of favorable outcomes. Now, the question then is, how do you do that adjustment? That is a whole other conversation that goes well beyond the scope of this topic that we're going into this evening. Because in chiropractic, we have at least 3 different systems. We've got an upper cervical system that starts from top down. We've got a foundational system that goes from bottom up. And then what do we have are called tonal methods that I would argue are not the same as adjusting a subluxation, but what they are doing is they are enhancing the adaptive capacity and allowing the body to function at higher levels, provided that there is no interference in its actual function. And as a consequence of that, people also get well. And oftentimes, you've got very few chiropractors these days who do only one of these. It's usually combinations and understanding. And who's right? It's whoever gets the outcome. Nobody's got it all figured out. I certainly don't. And we all still have an awful lot to learn from each other. So simply put, understanding that different does not necessarily make wrong, but understanding where and how the different systems can ultimately work together, or maybe we would be working on slightly different aspects of the same dynamic that we call health. That will ultimately, maybe idealistic, but allow us all to just get along a little bit better and respect. Even if somebody chooses to do something different, I see the perspective you're coming from. And if you got a favorable outcome, guess what? You did a good thing, helping somebody out. And this, again, is what we said. We're not saying that the ends justify the means. It's not true, but it's all about the outcome measure. In short, it's about, are you accomplishing what you are setting out to accomplish in terms of delivering effective chiropractic care? You don't get to control the outcome in terms of the symptomatology. Again, that's a matter of probability, not proven, not absolute, not certainty. Why? Because there is no linear relationship. All healing is a factor of the innate mechanical processes that go on inside of a person's body. You, the doctor, that is outside of your control. Quoting Clarence Gonstead, find it, fix it, accept it where it is, and leave it alone. Leaving it alone respects that innate healing of the patient's own body. That's what's responsible for ultimately achieving that outcome there. When we understand that, when we respect them, that this is the way that the human body works, this is the way that it heals, that despite our efforts to control all of the variables, there's a number of variables that are outside of our control. If we try to manipulate the outcome, that is by treating the diagnosis only without ever questioning what is the underlying cause, without analyzing what the true cause of those effects are, we're forever condemning a person to just keep spinning out of control just like that. When we understand these differences, when we understand this is cause, this is effect, this is the different way that you can get there. This then is where we as chiropractors will step in with science, with philosophy, with art. That then gives us a much better opportunity to make transformational changes in our patients' lives in, again, a way that no other practitioner is really looking at. This is what makes chiropractic special. And we're not unique in terms of looking for underlying cause. You will find GPs and specialists and nutritionists and physiotherapists, they are obsessed with not just treating symptoms, they want to know underlying cause. Professionally, these are the people that you're going to want to work with, because you realize that you each have different tools necessary in different situations, but it's all about helping people get to that ultimate health outcome, that is living the life of full expression the way that they really would like to. And if I am not mistaken, we've actually finished our presentation before the end of the hour. So jumping ahead, we will answer any questions that you guys may have here, but letting you also know, we do not currently have any seminars scheduled for the entire rest of 2022. In fact, I have not put the scratch as I was supposed to do, where we had just finished the advance up in Brisbane here. We might be planning and plotting a few things for the end of the year, because in brief, this is the little announcement. I think most of you already do know this, but in brief, I will be departing Australia for an indeterminate period of time, probably at least 2 years. And so I am in the process of selling my practice. It's under contract. I am on my way for departing Australia. Now, what I will do is I'm going to make an offer for people. If you want one more proper seminar, if you haven't had the ability to rock up, I will have a little bit of flexibility up my sleeve. I'm going to have a little window, but I'm going to basically need a pretty firm commitment from people to the point, shut up and take my money. I don't have exact dates, but I will try to aim for it in the very beginning of December. We're in the new year for your CPD. We will do either a single seminar or we're going to do the full thing over the span of 4 days. We'll work that out. But if that's the case, watch this space and make sure that you get in direct contact with me to let me know that. So I'll actually point out for you right here. Number one, this is my personal mobile right here. I haven't told you what it's going to be, but there's a typical rule. The seminar is going to be like all 3 seminars are usually around $2,000 total. If you are a first-year student, a first-year graduate, divide that by 2. And if you're a student, divide that by 4. And that would be the entire seminar series. You don't have to make up your mind right now, but if you're thinking that's something I really want to be a part of, send me a text right now. Just say, shut up and take my money. I know that you're committed if that's the case, at least verbally, that's fine. And if and when we put something together, if there is sufficient demand, I will make it happen. Just letting you know that. Putting it out there. But let's say you're like, oh, okay, no, I still want to get, a little bit more information. All of these are going to be happen one way or another from here. And that is going to be on the link that we have right here. We'll copy and paste it again for all you guys in the chat box. This is if you found that there was use and value in this evening's presentation. So this one here was module 10. Next month, November the 2nd. So again, the second Monday, first Wednesday of November, clinical decision making. I'm going to walk you through a few of the thought processes that go into the idea, should we be adjusting a person on a given day or not? What's the level of evidence that we should be looking at? Again, there's no absolutes in terms of this. You are the doctor, but we want to give you a few considerations. And so why do we put that at the end of the year? We do it especially for those chiropractic students who may be in their final year or their second to last year, and they're starting to get to the point of, okay, I need to start actually finding ways of putting all this together. So by putting it together, this is hopefully going to give you a few tools so that you can make better decisions and have greater confidence forward going. Now, I did ask if anybody had any questions whatsoever or any answers, because answers are also very much appreciated. I would like to have some every once in a while. But we ask you, simply put, the question, any questions from the evening's presentation? If not, that is a-okay, but we'll give it a couple of minutes in one way or another. Thank you guys very much, as always, for your attention, your attendance. I hope that you have enjoyed this. I hope that you found use. I hope that you found value here. And if not, sorry, we did the best we could. Cool. Everybody just says it was fantastic, no questions, so I presume that there's no issues. Okay, pop quiz. Just kidding, no pop quiz. What I will do instead, class, is I will let you out a whole 3 minutes early. So great having you guys out. Appreciated. We'll see you then next month, if not sooner. Oh, the one other last little thing. I will be speaking at the ACA conference in Sydney, October 22nd, 23rd. If you are in Sydney, if you are attending said ACA conference, it would be delightful to see you there. We'll be doing some familiar material, but I'm also going to be throwing in a few new surprises that I've never actually presented before. So that's what we got for you this evening. Thank you guys. See you next month, if not sooner. Take care then. Bye-bye.